Hello. Welcome to this session on anesthesia and airway issues in FOP, as well as a wonderful session on dental care, as well as treatment. Many of you have heard some of these speakers either at past FOP family gatherings, and you'll probably have new questions for them. And then some of you, these will be new sessions that you're hearing for the very first time. So we're excited for you to meet each of these dentists and a physician who are very dedicated to the FOP community and also dedicated to making sure that their colleagues understand how to treat and care for patients with FOP. So this is going to be a great session for you today. I do want to make sure that you're aware that right underneath the screen, you'll see a box. The first box is for chat. That is where you can speak with one another. There is a button for questions and answers. That is where you should put your questions for the panelists. We will address those at the end of the presentation after all three speakers have had a chance to present. So questions go in questions and answers, not in chat. And then you'll also see a link for Wordly, and that Wordly link allows you to access translation should you need it. You click on that button, and then it will ask you which translation you would like. There's up to 17 translations available, and then that will begin the translation for you. The last thing I would just mention is that you can move things around on your screen. So if you'd like to adjust the size of things on your screen and maybe make the video bigger, you are more than welcome to do that. So with the housekeeping out of the way, I am pleased to bring to you Dr. Zv Grunwald. He is from Thomas Jefferson University here in the United States, but also does an incredible amount of work in Israel. And he is the world expert on anesthesia and FOP. And so it's a real pleasure for you to be able to hear from him today. Zv?
Thank you, Michelle. And welcome and good morning to everybody. I'm excited to be here. And thank you to the IFOP organization that put together this wonderful program. I'm Dr. Sv Grunwald. I'm an adult and pediatric anesthesiologist and a pediatrician working at Thomas Jefferson University in Philadelphia. When you're planning for surgery, you've probably given a lot of thought to the education, the training, and the experience of the surgeon. But you may have not thought much about the anesthesiologist or the importance of his expertise to keep you safe and comfortable during your surgery. A colleague of mine, a pediatric anesthesiologist and a surgeon, stated that there is a big surgery, there is small surgery, but there is no small anesthesia. The role of the anesthesiologist is very important and carries major consequences, especially when he provides anesthesia to a patient with FOP. The goal of this presentation are to educate all healthcare providers about the perioperative management of a patient with FOP. The general practitioner will be able to assist patients to prepare for surgery, and my goal is to inform also the anesthesiologist how to plan for a safe perioperative care. So even you are not an anesthesiologist, at least you know what he should know and educate and talk with him about who are you and what you are, and I'll talk about it during my presentation. Alleviating pain and managing the emotional stress of surgical procedure are best done when we provide the patient the following type of anesthesia and analgesia. When the anesthesiologist uses sedative drugs given intravenously, it names monitored anesthesia care or IV sedation. The level of sedation ranges from drowsiness to deep sedation when the patient may not remember the events of the operating room. It is used in minimally invasive superficial procedures and can be combined with local anesthesia. When the anesthesiologist injects local anesthetic, this is called local anesthesia or nerve block. When a dentist gives you an injection, This is an example of a nerve block. An injection of local anesthesia is given through a needle or a catheter to numb an area of the body where the procedure is performed. Nerve block can be used to perform a surgical procedure combined with general anesthesia and can be deployed to control pain during early post-operative period. The other option is using anesthesia gases, general anesthesia. During general anesthesia, the patient is unconscious, and this technique is used for major surgeries and in children. It is important to remember that injections are not recommended for patients with FOP because they may precipitate flare-up, and the flare-up may cause formation of heterotopic bone. This is an example of heterotopic bone formed after a diphtheria, tetanus, pertussis immunization in a boy with FOP. However, we learned that needles can be administered safely to patients with FOP under the following circumstances. Submucosal dental infiltration, subcutaneous immunization, and the insertion of intravenous line. We also learned that in advanced cases of FOP, nerve block can be used to successfully without further escalating the FOP status. This is an example of the use of a nerve block in a patient with FOP. A 44-year-old patient suffered from life-threatening antibiotic-resistant bacterial infection of the right lower foot, and she was scheduled for mid-knee amputation. General anesthesia was deemed too dangerous. The jaw of the patient was locked, she couldn't open the mouth, precluding the placement of a breathing tube orally. Advanced kyphoscoliosis and limited chest wall movement created thoracic insufficiency syndrome that could precipitate respiratory failure and prevent successful extubation of the trachea after surgery. The anesthesiologist performed ultrasound-guided femoral and sciatic nerve blocks. The local anesthesia was administered by indwelling catheters, and the analgesia was confirmed before the surgical incision. The surgery was performed successfully under sedation only, and this case was published recently in August 2020. With a very few exceptions, all surgical interventional procedures should be performed under general anesthesia. The technique is safe, has good clinical record, and can be used in inpatient and ambulatory situations. Physician and patient may be tempted to use sedation technique and perform minor surgical procedure at an office-based or outpatient facility. The risk of catastrophic airway emergencies are far outweigh the potential benefit of this option. Let's take, for example, a simple procedure, a colonoscopy. Most colonoscopies are performed under intravenous sedation. The major complications that can endanger the patient are bowel perforation by colonoscope and apnea from oversedation. At this time, there is an urgent need to safely secure the airway by inserting a breathing tube to the trachea. The problem is that the patient with FOP have a stiff neck and very limited mouth opening. So the chance of safely and timely intubating the trachea and preventing a catastrophic outcome are slim at best in patients with FOP. And even if the patient can open the mouth, performing direct laryngoscopy for intubation can cause the temporomandibular joint to fuse and the mouth will be shut for life. we need to perform nasal fiber optic intubation before the surgical procedure. We have been counseled and called for FOP patients from around the world, and in cases where the anesthesiologist was not familiar with nasal fiber optic intubation. So we strongly recommended to transfer the patient to a medical center where an expert anesthesiologist performed the nasal fiber optic intubation, and the procedure was done safely. The anesthesiologist will gather medical and non-medical information about the patient in order to create the best plan to provide safe anesthesia during surgery. The information includes the age, weight, height, BMI of the patient, allergies. He should focus also on comorbidities like asthma, diabetes, and on cardiac and respiratory systems. He should record all medication that the patient is taking, including over-the-counter and herbal additive. He should ask about previous surgeries, previous anesthesia, and if there were any problems with anesthesia in other members of the family. Special attention is dedicated for FOP issues: the age when the patient was diagnosed with FOP, recent flare-up, and body parts affected by the FOP. The impact of daily living, dependent or independent, and whether the patient is participating in a drug study. Careful examination of the airway and the respiratory system is routinely performed by all anesthesiologists. It is of paramount importance in FOP patient, so the anesthesiologist should examine the neck for range of motion and the opening of the mouth if it can be opened. Mouth opening is also important because it can affect the ability of the patient to remove secretions and vomiting. The skeletal abnormalities like kyphosis and scoliosis have profound effect on lung volume and the respiratory reserve. He should record changes in heart rate and rhythm. He should document mobility or immobility and observe for changes in body posture. These issues need to be addressed when positioning the patient on the operating table. Connecting with companions and family is very important. You need to invite them early into the recovery room early after surgery so they can comfort the patient and assist and guide the nursing team. Here is my list of the 10 commandments for the anesthesiologist when providing anesthesia for FOP. In order to optimize the chance of a successful anesthesia, the anesthesiologist must meet with the patient at least one day prior to this procedure. He needs to assemble a team, assure open channels of communication between all parties, secure the airway by nasal fiber optic intubation, and give intraoperative steroids. He should not rush during the induction procedure, avoid direct laryngoscopy, and pay special attention to protecting the patient when they are unconscious. FOP patient deserves special measures throughout the perioperative time. At Thomas Jefferson University Hospital, we assembled a team of experts focusing their attention on the FOP patient. For example, an ENT surgeon is always available to stand by in case to perform an emergency tracheostomy in order to secure the airway. The nursing teams, and we have many of them, are caring expertly for the FOP patient along his journey from the holding area to the operating room, recovery room, the critical care unit if the patient needs to go to, and of course, on the floor. Each time when I check the operating room before surgery, I'm confident to identify the tracheostomy kit. It's ready because it's an integral part of the case card for surgery. This is just one example for a preset system recreated at Thomas Jefferson University Hospital to care for patients with FOP. We involve medical expertise early, and we prepare the hospital sites to become FOP-friendly to accommodate for the special and physical needs of the FOP patient. Undergoing a surgical procedure is a major event in the life of an FOP patient. It's their day in the Olympics. The best training, what we call prehabilitation, is dedicated to make the respiratory system stronger. And the goal is to bring the patient to the operating room at his best physical, emotional, and spiritual shape in order to optimize a great outcome. We allow the patient to wheel herself to the operating room, and this patient is fixed in the sitting position with her hand is the only freely moving extremity. We prepare ample blankets on the operating room table so it will help with positioning of the patient. This patient hand is fixed in adduction close to the chest wall. Applying a blood pressure cuff may be challenging, and sometimes we place the cuff on the leg. We tilt the OR table and add padding and support to accommodate for body configuration. We use routine monitoring that require in most surgical procedures EKG, non-invasive blood pressure, pulse oximetry, end-tidal CO2, and body temperature. If the patient has significant comorbidities, the procedures deemed to be long surgery, or maybe the cardiovascular system is compromised, then we may require additional monitoring. This is a typical position of the OR table for a dental procedure, so the dentist can reach the oral area. This position may cause a patient some discomfort and result in respiratory compromise, especially in patients with pre-existing pulmonary disease. No question the patient needs to be asleep. All pressure points must be padded and the neck supported. We include padding the patient's shoulders and securing the patient to the bed to ensure that the bodies do not shift in the operating room during the procedure. I leave always part of an extremity exposed so I can monitor visually the quality of oxygenation and circulation independent of the electronic monitoring. We bring to the operating room an airway cart with a fiber optic scope used for nasal fiber optic intubation. You can see the fiber optic scope and the syringes with lidocaine to inject and anesthetize the larynx during the procedure. We pay special attention to protecting the body and extremities by using foam, blankets, and gel pads around the patient. We encourage our young patient to bring a friend to the operating room. And of course, the friend is there waiting when they wake up after surgery. After surgery, we aggressively treat pain and nausea and vomiting and provide ample of emotional support to the patient and their families. After surgery, we are aggressively treating the pain, as I mentioned, and as you can see, after the result of surgery in an outpatient with FOP are published in individual case report. We were surprised that after a dental procedure, as you can see here, the patient was kept in a hospital for 4 days. Not shown here, there was a report of a 7-year-old girl that underwent a dental procedure in a dentist's office under sedation. She suffered catastrophic outcome. So we decided to publish our experience in providing anesthesia to 30 FOP patients undergoing 42 surgical dental procedures at Jefferson. Dr. Elaine Kilmartin published the result of this survey in the journal Anesthesia and Analgesia in 2014. Here you can see that almost half of the patients were at pediatric age. 86% of the patients were discharged from the hospital at the same day after surgery. 14% were kept one night to monitor for comorbidities like asthma and diabetes. It is important to notice that all our patients had smooth perioperative course without any adverse outcome. To date, we have performed more than 100 surgical and interventional procedures for patients with FOP with excellent results. We are routinely treating patients with FOP for about 20 years. The keys to success are excellent collaboration between medical specialties, good communication, and we constantly modifying techniques, for example, how to treat patients who cannot open the mouth, how to intubate the trachea, how to perform complex dental procedure, and so on. We try to improve the techniques for maintaining the airway when we lose the airway incidentally. We have strong endorsement by the hospital administration, and our hospital and university leadership are proud that we are having a center with global distinction providing care for FOP patients coming to Jefferson from all over the world. Our multidisciplinary center is open every day, all year round. We provide medical expertise and counseling for non-medical issues. We care for FOP patients throughout the lifespan. My personal hope is to see these centers thrive, at least one in each continent. We have cared for FOP patients arriving from 5 continents, and our team treated patients at their homeland. This is a patient recovering for surgery by our team in Jerusalem, Israel. And this patient developed acute abdominal problem that needed surgery, and we sent our helicopter to another state and a team to transport the patient to Jefferson. This is a view from our helipad at the top of the hospital. Over the last years, we are providing consultation for FOP patients with fertility challenges, intraoperative pain management, and invasive medical procedure like thoracentesis and chest tube insertion. More recently, we are using 3D printing to guide important clinical decision and management of our patient. The first example is a 26-year-old FOP patient with recurrent lung infection at the collapsed lower lobe of the lung. The question was, can we insert a stent to allow for the collapsed bronchus to open, improve aeration, and resolve the left lower lobe infection? This is a 3D image of the chest of the patient. You can see the heterotopic formation at the site of the sternocleidomastoid, the pectoralis, and bone connecting the right humerus to the chest wall. Severe scoliosis to the left reduces the volume of the left hemithorax. The trachea and the right bronchus are normal, but the main bronchi on the left are obliterated. This is a 3D printing of the normal trachea on the left side, and the trachea and bronchus of our patient are clearly showing on the right that the bronchial tree is obliterated, especially at the left lower lobe. This is an actual 3D printing of the same patient. You can see how the chest wall, you can see the heterotopic bone formation. And when I tilt it, you can see actually the scoliosis to the left. You can see the limited volume on the left chest. You can see the trachea, bronchial tree on the right, and the limited space and the bronchial tree on the left-hand side. We decided not to pursue the stent insertion. More recently, a 26-year-old FOP patient with recurrent life-threatening infection of the uterus presented for hysterectomy, a major surgery, under general anesthesia. We created a 3D model of the thorax, and here it is. As you can see again, heterotopic bone formation of the chest, but if you look inside, you can see that the spinal column is straight, the beauty nicely open both chest cavities, and if you look, you can see the trachea and the bronchial tree nicely branching out. So we deemed that the respiratory system is doing well. So we thought that the patient has a chance for a favorable outcome based on the following factors: a healthy respiratory system, a chance of having good post-operative pain control if we insert nerve block to the abdomen, so she will need less opioid and less chance for respiratory depression. As you can see, experts from many disciplines of medicine participated in her care: gynecology, general surgery, urology, pulmonary medicine, anesthesia, pain management, critical care, and of course, our wonderful nursing team. We secured the airway with nasal fiber optic intubation of the trachea. We provided good pain control with the nerve blocks that I mentioned. Surgery went uneventful, and she texted me at the evening, "Dr. Grunwald, I'm walking." She was discharged from the hospital after 2 days. I would like to conclude my presentation with Whitney, and she will tell you her and share with you her experience. How was the surgery, anesthesia, and the perioperative care at Thomas Jefferson University? Thank you for participation and have a wonderful day.
Hi, my name is Whitney Weldon, and this past fall I ended up in the hospital twice getting sepsis, and we were unsure of why I was getting it. During my second stay at NYU Hospital, they communicated with the FAPD team down in Philadelphia, trying to solve the mystery of why I was getting sepsis and in so much pain. I was experiencing so much pain in my right thigh. I was concerned that it was my FOP. Although in December, the FOP specialist did not want me to go to prednisone because she thought the pain was actually stemming from my uterus. For my first consultation, Hi, my name is Whitney Weldon, and this past fall I ended up in the hospital twice getting sepsis, and we were unsure of why I was getting it. During my second stay at NYU Hospital, they communicated with the FAPD team down in Philadelphia, trying to solve the mystery of why I was getting sepsis and in so much pain. I was experiencing so much pain in my right thigh. I was concerned that it was my FOP. Although in December, the FOP specialist did not want me to go to prednisone because she thought the pain was actually stemming from my uterus. For my first consultation at Jefferson Hospital, we met with a variety of different doctors, including Dr. Grunwald, Dr. Kaplan, Dr. Park, and a few others. While I was at my consultation, the team discussed with me what would be going on. After my consultation, we scheduled the surgery for February 20th, 2020. When I arrived in February in Philadelphia, we had a pre-surgery meeting with about 30 doctors, which was pretty incredible. After surgery, they put me in the ICU for a few days to keep me under watch. Once I woke up from the surgery, the first thing I told my mom was that my pain was no longer in my leg. It was pretty incredible. Not only were the doctors incredible, the ICU team was amazing. They made me feel just at home, and I didn't think for a second that I was alone and that I had a rare.
Wonderful. Well, thank you so much, Dr. Grunwald. It's always great to see your knowledge is incredible, but your heart and the way you care for the families in our community, it just means so much to us. And it was great to hear about Whitney's experience as well. So next up, we're going to switch to a related subject, and we're going to talk about dental care. And you'll see throughout the presentation that there is some discussion about treatment, and at times, both of the doctors that you're going to meet have been called in to help with interventions. But you're also going to learn a lot today about how important oral care is. It's important for all of us. Proper oral care is important for all of us, but it's especially important in FOP patients. And so you're going to learn a little bit more about that today, some things that you can be doing, and then also some things that you should be asking your local dentist. So we're going to start off today by hearing from Dr. Corey Crowe. Her practice is here in the United States, New Jersey. And there's a good number of FOP patients that live on the East Coast, and many of them do see Dr. Crowe. So she may be a familiar face to you. And with that, I will turn it over to Dr. Crowe.
Hi, everyone. Can you hear me? Hello? Can you hear me? Okay, so I just wanted to let everyone know that with the FOP community, it's a very intricate airway, like Dr. Grunwald said, and I treat everyone with FOP that, like she said, that live on the East Coast. But I also talk to a lot of dentists worldwide who see patients. So it's important, like Dr. Grunwald said, to, if they need the OR, to do the fiber optic awake intubation. So as far as anesthesia, I always encourage the patients that don't live near us and who are planning on OR to either try to have a consultation with our team, or at least for our team to communicate with the team that is taking care of the FOP patient where they are. There are, Dr. Clive is going to speak about the fact that there are patients that it is important to have the oral care for everyone, whether you have FOP or not, but it is important for routine home care as well as seeing the dentist every 6 months for a preventative type care. However, if they have cavities and they can open, they can be seen in the office. And like Dr. Grunwald discussed, local anesthesia is okay as long as it's not a block. Infiltration is fine. And I've treated a number of FOP patients quite successfully in the office and hadn't had any adverse effects. However, if they have limited opening or they have a number of cavities and they need to be treated in the OR, we have an FOP team together that can take care of that. And we also work intricately with the oral surgeons at Thomas Jefferson University and Dr. D.D.S and his team, and they perform the actual oral surgery portion of it, whether it be wisdom teeth extractions of teeth in general, and things of that nature in a very safe environment. I will do the restorative portion of it, and that is just the cavities, the caries control. And if a patient can open, then we fill the teeth as normal for anyone who doesn't have FOP. However, it becomes more challenging if they cannot open. And if that ends up being the case, then we will have to go through the side of the tooth to get to the cavity. Typically, if they open, we take x-rays after they're asleep and get a treatment plan that way. However, if they have limited opening or they are fused shut, then we order what's called a lateral ceph x-ray from Thomas Jefferson University's radiology department, where they send someone down and they actually take the x-rays for us of the right and left side. That way we can know exactly what is going on and what is needed. We fill the teeth with white fillings and we keep it quite aesthetic. I have seen a number of FOP patients who are afraid to go to the dentist. They're afraid of opening wide. They're afraid of flare-ups. And all these concerns are very legitimate and very important to address. So communication is key with the patient, key with the parents, and key with the dentist and the FOP team. On that note, we will decide what treatment plan is best, and typically I will even call the family from the OR if it's a mother of a child and let her know what I found from the x-rays and what the treatment plan is going to be. I also like to see them post-operatively. If I cannot see them because they've traveled from a different state or country, then I usually try to check either via email or phone. There are a number of dentists that call myself and Dr. Clive, as well as Dr. D.D.S, to discuss what they need to do with the patient in their country or state. And this is something that we do pretty much 24/7. Being a part of the FOP team has been a challenge because it makes me stretch my mind, but by the same token, I have a compassion for this this disease and for trying to make them as comfortable as possible and keep their oral care optimal. So doing the preventative care is essential, as well as being a part of the FOP team and pulling from our expertise to help in any way possible. And again, I said that it is typically done by a phone call or by email or someone on the FOP team reaching out to us on behalf of a patient that needs our expertise. I'm happy to be here. I'm happy to help, and it's a privilege to present to you today. And I appreciate the hard work that went behind the scenes from the IFOPA group to put this together. Thank you.
Great. Thank you so much, Dr. Crowe. Again, we are so blessed with having medical professionals that just really embrace our community. So our last presenter today is going to be Dr. Clive Friedman. And I think that the first time I met Dr. Friedman is when we were together in Argentina at the family meeting being run for Latin America by Moira Liljeström, who runs FOP Fundación FOP in Argentina. And he was down there and meeting with families and meeting with other dentists from the area. And, immediately I saw how passionate he was about working with our families, and then also, making sure that he was giving them the best advice, but in a way that really helped each of them. So you will get a sense of that as he shares his slides and as he talks with you this morning. Don't forget, if you have questions, if you'll share those in the chat. And with that, I will turn it over to Dr. Friedman.
Thank you, Michelle. It's indeed an honor and pleasure to be here with all of you today, and to have been invited by IFOPA to present. I always learn something both from Zv and Corrie with respect to working, and the ability to be with this community and to advise and help with treatment is remarkable. Today, what I normally do on this presentation is I present a lot of information with respect to risk management and prevention. Ideally, you never want to end up in the operating room with Dr. Grunwald or with Corrie. So my focus has always been on minimizing one's risk of actually ending up in the operating room. With respect to risk management, I am actually not going to be doing much of a presentation today because I have done a webinar on risk management, which is available through IFOPA. What I wanted to do today, however, is to and here is the website where you can actually get the webinar that we spent a good hour on a lot of the aspects of risk management and prevention. And I would encourage you, if this is something that you're interested in going to look at. So what I wanted to do today instead was to look at a number of the issues that have arisen over the last year. Many individuals will either email me or call with respect to something that's been going on. And I wanted to identify what these have been over the last year, because they have changed with individuals staying at home, with COVID, with decreased office visits. As you all know, my normal recommendation is that for individuals with FOP, that they be seen at least on a 3-monthly basis. With the complete shutdowns in many countries, this is deemed to be impossible, and many individuals who would normally get ongoing care have not been seen for over a year. So with the decreased office visits, one of the things I do not know is, have there been an increase in flares due to dental or oral health untreatment, where there has not been any treatment? What I have seen, however, is an increase in pain. And that pain can be due to a number of issues. It could be due to increase in grinding, increase in fractures. Now, with the COVID, this is a result in dentistry that we have found across the population. So it would make sense that individuals with FOP would also have similar kind of findings, where they are increasing their bruxism or grinding of their teeth. And with that, you get abfractions or fractures of the teeth. We've seen an increase in abscesses. We've seen an increase in pericarditis. What is pericarditis? It's essentially inflammation or infection around an erupting tooth, most commonly around an erupting wisdom tooth, but it can be seen in the primary dentition as well. I've been in discussion with dentists where there's been an increase in periodontal disease due to the fact that individuals are not getting their ongoing cleanings. And with COVID, we've seen an increase in sleep disorders as well. So COVID has been quite an issue with respect to what has been seen in, or what I've been listening to from many parents and from many individuals who write in. So the question becomes, what do we do? What do we do with this dilemma? And what road should you as a patient with FOP or as a parent take that will help you move beyond this? This road that you take is going to be very dependent on the support systems that you have. You heard from Dr. Grunwald the need for intense management teams. Does your country, does your area have such a team? Do you have the support system available to you in dentistry, in medicine? So a lot of times it's not just what's happening, but it's also about the support system you have. And fortunately, members of the FOP community have access to the ICC. You have access to all of us in the ICC, and many of us will respond to you very quickly with respect to your needs. The other thing that I have noticed is that with this increased infection, we've had an increase in antibiotic prescription. And how many times can one be given an antibiotic for an infection? Let me talk a little bit about grinding and the cause of grinding. So with increase in stress, with increase in what might be happening in terms of sleep disorders, you will find that grinding will increase, and it can also occur in those individuals who are completely closed. So if you've got complete fusion, you can still be grinding and bruxing your teeth. You can still fracture your teeth. And in my sense, in my viewpoint, and this would be my own biased viewpoint, if you will, that a fracture of a tooth or infection of a tooth is an essential service, and that does require immediate care. So it is not something that can be delayed for 3 to 6 months if you're in shutdown. Recently, we have been once again shut down completely in lockdown, and the individuals, I have one individual who I've been working with since March, and we have still not been able to get care for him due to the inaccessibility of the operating rooms because of lockdown. So this poor individual has been on a large number of antibiotics due to ongoing infection. If you have, let me just talk a little bit about one of the things that you can be doing if you've got increased grinding or if you've got bruxing, is if you have sufficient mouth opening that an impression can be taken, certainly you can and should get a mouth guard made for you that can help protect your teeth. And the other piece with grinding that I'm curious about is it increases the activity of the masseter muscles, of the temporomandibular joint muscles, of the temporalis muscles. And with increased activity of those muscles, do we increase anoxia in those muscles? And does that result in increased flares? This is something that I do not know. And it would be interesting to hear if individuals have had some of this occurring. Just recently, I had an individual say that the mouth opening over the last year has decreased considerably, and there's been no absolute flare, but the parent did not know why the decrease in opening had occurred. And I wonder if some of this may be due to anoxia, due to bruxing or grinding of the teeth. We have also seen, as I said, an increase in the infection of where you have a completely broken down tooth, which results in inflammation and infection. These teeth really require extraction. Can we do anything about this? And what do we do in terms of delaying treatment during this period of the pandemic? Antibiotics, mouth rinse, increasing cleansing is all good. The kind of mouth rinse that you would be using would be dependent on the problem and what you're trying to use the mouth rinse for. So I would absolutely urge you to talk to your oral health professional about the kind of mouth rinse that is best suited for the particular problem that you may or you may not be having. They are not all equal and they don't all do the same thing. So it's not like going to a pharmacy and just taking a mouth rinse off the shelf and using it. Please do speak to your oral health professional so that they can prescribe for you the appropriate mouth rinse for the appropriate problem. The question has arisen many times over the last year is, can an extraction be done with FOP? And the answer to that is absolutely, it can be done. But as Dr. Grunwald was clearly saying, it depends very much where it is in the mouth, the amount of opening that is currently present. And for example, in this X-ray, you can see this tooth on your right as you're looking at the screen. The second tooth from the back has got a large infection. And this is in a mouth that is completely fused, that is in the lower jaw. Even if this mouth was not completely fused, due to the fact that this tooth is in the lower jaw, the kind of anesthetic required to remove this would not be possible under local anesthesia. And this is the type of instance where it's absolutely essential that, as Zv was talking about, that you have a general anesthetic in order to remove this tooth. What do we do, however, in instances where you do not have access to anesthesia, where you do not have the support system that can provide it for you, or if you're in lockdown? So ongoing antibiotics. One can also do what is called incision and drainage. So these are things that are absolutely essential, and we want to try and prevent that from happening. I will remind you that if you want to have a look at the suggestions in terms of what can be done orally, that is in the guidelines. And remember that we always need to do prednisone preoperatively, especially if we're doing extractions. Now, in terms of periodontal disease, or what we call gum disease, and you will know if you've got gum disease if you brush your teeth and you spit and you see red or blood in the sink, you have periodontal disease. You have infection of your gums. Ideally, if you brush your teeth, you do not want to see any blood when you're spitting into the sink. And just a quick reminder that why we actually brush our teeth. If you have a look at this these two slides, I am sure that most of you would not want to swim in the swimming pool in the lower section of the slide. And that's what happens when we do not put chlorine in the pool, where we do not keep the pool clean. And eventually, this biofilm or bacteria continue to grow and cause an unholy mess. This exact same thing is happening in our mouths. When we do not take daily care of our mouths and disrupt the biofilm or the bacteria in our mouths, we result in both periodontal disease as well as an increase in cavities. So when I ask people if they are flossing, for example, they say, yeah, maybe once a week. And what's curious to me is if we're brushing twice a day, why are we not flossing twice a day? Because that is the area that gets the bacteria between the teeth disturbed as much as brushing is doing it on the sides of the teeth. So it's just a quick reminder to folk in terms of why we actually do daily care with respect to our mouths. Now, there's a complete palette of what we can do and what creates and what are some of the things that can be done to minimize dental or oral disease. I covered this palette and the details of this in much more detail in the webinar. So please do have a look at that webinar if you want to see the details of many of these issues that I have identified here in terms of the microbiome and in terms of how we can minimize disease long term. I've had the question many times, should a person with FOP have their teeth cleaned by a hygienist, and if so, how often? And again, this is oftentimes we are not able to completely clean our own teeth. And if we have the buildup of calculus, which a toothbrush or floss will not get rid of, you actually do require the services of a healthcare professional to get you into that place of balance, or where your teeth are able to be cleaned correctly and daily just with a toothbrush or flossing. And so it depends on the state of one's dentition and the amount of buildup and the difficulty you may or you may not be having in terms of getting to an area. If you've got complete fusion of your wrist or your elbow and it's difficult for you to brush, well, then you might need to see a hygienist more often. And that more often could be anything from 6 weekly to 3 monthly to 6 monthly. It depends, again, very much on your circumstances, what you're able to do, and what access you do. Unfortunately, very often, there's also financial issues related to this. And I'm sure if you speak with your oral care professional, you'll be able to come up with some kind of a program that would be suitable for both of you. I've had the question in terms of what to do to clean behind the teeth, especially if your mouth is completely closed, you have limited opening, and you cannot get in. If your mouth is completely closed, you can always brush the outer aspects of the teeth. You can get that done extremely well. You do not need to have an open mouth to brush the outer aspects. So you should never really get these white lesions on teeth that you can see in this particular photo over here. What do you do between the teeth? Again, in the webinar, there are a number of additions that I have identified that can help you to get to the inside of the teeth. And this is where you might also want to be using particular mouthwashes. So the adapted tools are numerous, and they are really dependent on what you have available and your imagination in terms of what you can do to get to some of these areas. I've seen some individuals with quite the remarkable adaptations that have enabled them to get to areas that one would not think is possible. Now, a lot of the questions that I get are, what do we do when the jaws are completely locked? How do we fix cavities? What do we do if you get sick and you want to throw up? And what do we do if we need extractions? So this is where, if your jaws are completely locked and you have dental disease, and unfortunately in the family gatherings that I've attended over the last number of years, it has been quite remarkable for me to see the number of individuals with completely locked jaws that have got actually quite extensive oral disease that could be impacting their overall health from many, many different perspectives. And so I would encourage individuals with locked jaws to make sure that you see your oral health professional as often and as many times as you need. Can we do treatment, as Dr. Grunwald has identified? Absolutely. Treatment can be done with nasotracheal fiber optic intubation. under general anesthesia. One can get in and do extractions of teeth. My recommendation oftentimes is to extract back teeth, which you're not using anyways. That would make a hole that you could expectorate, that you could vomit through, that you could eat through, that you could place tablets through. My predecessor, who did a lot of this, Dr. Bert Nussbaum, often would do extractions in the front, in the lower anterior area. My own personal preference is this is an important area in terms of aesthetics, in terms of how people view themselves. And if I can possibly help it, my preference is to have extractions done in the back area of the mouth so that it enables an individual to eat, swallow, take tablets, vomit in a perspective that we don't really need those back teeth if our teeth are completely locked. So it is possible. It is complicated, as Zv says, and I would like to see prevention of it rather than the need for treatment. I am pleased to say that IFOPA have currently come up with a methodology for those individuals who do not have the financial wherewithal to get transport or to get to Jefferson or to get some treatment, that there may be some help for individuals to actually get this treatment. And I would urge you to contact IFOPA and speak with them about what is currently possible. We spend a lot of time with other aspects of health, and I cannot urge you enough or stress enough the importance of maintaining the oral health of you as an individual, because this is as important as any other part of our bodies. Because remember, what goes into our mouth is also the entry point for the rest of our bodies and the health of the rest of our bodies. So everything we eat results in something in terms of what we do and how we do it. Wisdom teeth removal, should it be done? Should it not be done? This is oftentimes a question that I am asked. As a whole, I follow Dr. Kaplan's advice. If at all possible, I do not like taking out teeth if it's necessary. We have to remember the risk-benefit ratio of removing teeth. If we can possibly stay a general anesthetic and not extract teeth, it is important. But one has to have a look at the risk-benefit ratio for every individual based on their needs, based on their airway, based on many of the aspects that Dr. Grunwald has already identified. And this is where the team is absolutely essential. So these are some other questions that have come up over the last year, which I wanted to address for you. Does diet beyond the basic eating and drinking of sugar affect our oral health? Absolutely it does. Diet is essential in terms of what we eat and how we eat and the nutrients that we have. It affects the overall microbiome of not only the mouth, but also of the stomach, and that affects overall health. So it's important that we have some sense of our overall diet, and hopefully IFOPA is dealing with it in some of the alternative programs that you have. Drinking milk does not necessarily give you stronger teeth. The strength of teeth is based on genetics, it's based on development, it's based on the amount of calcium and fluoride that is available when our teeth are actually developing, oftentimes in utero. So milk in itself will not necessarily give you stronger teeth. Your teeth are going to be as strong as they are when they come in. What impacts the strength of teeth is the acid production over a period of time and whether that eats away at your teeth or not. The question on how often to visit the dentist, I've already identified to you. It's going to be very dependent on every individual's need and their risk of developing disease. And I don't have a specific toothpaste or mouthwash that you should be using. Again, it's going to be dependent on the need that you have and what it is that you're attempting to prevent or treat. Generally speaking, I regard any individual with FOP as being extremely high risk for developing disease, and therefore I recommend a high-dose fluoride toothpaste to minimize onset of disease, especially if you're able to spit. If you're unable to spit, then you do not want to be using a high-dose fluoride because you're going to imbibe too high a dose of fluoride. And then what is the best thing for treating dry mouth? Again, it's going to be dependent on what the cause of that is. For many of you who are on drug trials, many of the side effects of those drugs is dry mouth. And if you're aware of that prior to, then you can know exactly what you're needing to do. Dr. Delay spoke really clearly about some of the things you need to be doing in terms of prevention of superficial skin issues. Very similarly, it's going to be the same in the mouth. There are a number of products that you can use to help you with maintaining a moist mouth. And again, these I identified in more detail in the webinar, but speak with your oral professional. And it's always a good idea for many reasons to increase the amount of water intake that we have. For most of us, we do not drink sufficient water a day. And I would recommend that every time you have a snack or eat, have a glass of water, swish, swallow the water, and that might also help with the dry mouth. But there are products available that can help you, and please do discuss these with your oral health professional. This is a slide that I show that shows the complexity, and it's a tough slide because you can't really see it, but you can see the number of different things that result in the shifting the overall microbiome and the underlying issues related to health. A question I often get answered is, can I wear braces? My teeth shape is not the best. Can braces be used in individuals with FOP? Absolutely, braces can be used. My recommendation is normally to use Invisalign and not the full braces that makes it difficult to keep the teeth clean. But again, it depends on why you're wanting them, the braces done, what it is you want to accomplish, and how it can be done, and whether you in fact have a opening that impression is going to be taken or not be taken. And this is going to depend, and this is going to impact whether you can have braces or not. Just because you have FOP does not mean to say that you cannot or should not have braces. Can teeth be fixed in FOP? This is a young boy that you can see has got extensive amount of disease. He had FOP, he had wide opening, and he was able to have all of that treatment done, not under general anesthetic, but under local anesthetic over a period of sessions, and could have a very nice fabulous result. This was done by a dentist in Mexico, a pediatric dentist in Mexico. So you do not need to have access to myself or Corey, but there are individuals all over the world who do have the ability to treat individuals with FOP. As long as they follow the guidelines, everything should be absolutely perfect. And there are some very specific things that one can do. And both Corey and myself are open to discussing these with dentists if they ever have any questions. So the risk-benefit ratio is always an essential aspect of care. Corey spoke about the x-rays. We can, if you can stand up in an x-ray machine, even if you've got a locked jaw, you can actually have what we call external bite wings taken. And here's an x-ray of an individual with a closed jaw, and which gives us a very nice viewpoint of all the teeth in the mouth, what is happening and how it can be done. There are certain individuals that cannot, because of their joint flexibility, cannot stand or sit in an x-ray machine. And for these individuals, we can either have a cone beam or a, as Corey mentioned, a lateral cephalograph, or even a, so things are possible, but becomes much more complex and difficult. I would continue to urge individuals whenever you go to the dentist to make sure that you have a baseline opening. Yesterday, Dr. Kaplan identified the importance of it. Dr. Grunwald continues to mention the importance of the airway as well as the ability to breathe. So some of the things that you want to make sure that your dentist does that I am reminding you of is always at a continued baseline opening, as well as a baseline of your PCO2 or your ability to oxygenate your blood cells. And most dentists will have the tools to determine this. And especially if you're going fairly often, it's something that you want to have as an ongoing baseline. Now, obviously, many families have there's so much to deal with when you are working with FOP. And I just want to urge you that oral health should and could be as much a primary focus as anything else, because it can be absolutely devastating in terms of destruction, or if we do not have good health in the mouth, it can impact our quality of life, and it can impact other issues as well. So please don't deny or ignore the aspect of the mouth. So at this point in time, I would like to stop. I would like to thank everyone for their kind listening. And Michelle, I'm going to open this up now for questions. Thank you very much.
That's great. Well, thank you so much. So many great tips and ideas and reminders, all coming from the lens of the community. So we really appreciate your perspective. So we have, if you have questions, don't hesitate to ask them on the screen in the questions and answers box. I will, before we start, just let you know that if you didn't see it in the chat, I added the link to Dr. Friedman's presentation from this last April, the presentation he was referring to. It is on our YouTube channel. So if you go to youtube.com/IFOPA, and then you will find it there under FOP resources and support. But you do have a direct link to it here in the chat. You'll also see that I've linked you to the page on our website, Oral Health and Dentistry. And that has some of the tips and ideas that Dr. Friedman was talking about. And then it also has information for the travel stipend program that he mentioned. So as both Dr. Crowe and Dr. Friedman and even Dr. Grunwald alluded to, that there is an opportunity that some patients and their families have traveled to Thomas Jefferson University to have oral surgery done. And there's a process to go through to see if your insurance will cover that. But part of the issue for people with getting there is the travel cost of getting to Philadelphia. And then oftentimes you have to stay for many days, for several days while you're there, maybe even up to a week. And so the IFOPA is now providing a stipend program. You can apply to receive that stipend to help underwrite the travel. for that type of dental work. So you can see the parameters of that stipend program on the page that is linked to in the chat. And I will say we are, it's almost Giving Tuesday. It's hard to believe it's the end of the year. Giving Tuesday is coming up on December 1st. And that is the focus of our Giving Tuesday campaign, is to raise funds to be able to provide those stipends. So it's an important thing. If you get involved in Giving Tuesday, either by giving or by promoting it, I hope that you'll be a part of our campaign to raise money for the dental stipend program. Okay, so with that, we will respond to or ask some of the questions. So the first question that was posed here is around intubation. And I think we just want to kind of retouch on what was said. The question that was asked is it difficult to intubate FOP patients due to narrowing of the airway? And I believe, Dr. Grunwald, if you want to take that, you talked about fiber optic nasal intubation as an alternative. So maybe you could talk about that just for a minute.
So it's of prime important to go and have an anesthesiologist and a system. And it's not just the intubation. It's really the total care of the patient that I'm talking about. You need experts who have done fiber optic intubation before, seasoned in nasal fiber optic intubation, but it's not only the technicality for the anesthesia, because a patient coming for any procedure, it can be dental, it can be gynecology, as I mentioned, it can be general surgery, can be neurosurgery. So the issue is having a team that knows about and collaborate to care for the patient. As mentioned, and Michelle mentioned, usually we try to limit the time that the patient come to Philadelphia. Yes, I was asked about intubation, but it's a whole setting. We try to invite the patient to downtown Philadelphia, have minimal time lapse between the preoperative visit so we can physically check the patient, examine, introduce our team, assemble a team, and the day of surgery. And most of the time, if it's a simple, straightforward procedure, we would like our patient to get out of the operating room, recover in recovery room, and leave the hospital on the same day. Stay in town overnight just to make sure that any issues that can be simple, pain management, will not be emotionally or costly to the family. We're available 24/7. We can assist for recovery. And if everything is fine, then they can take the road, drive, fly back to the home and live safely. So truly, it's you. And again, we have done it. And Michelle, the good question is about intubation. It's many times we actually assemble the team wherever the patient home is. So if you have a good academic center or an anesthesiologist and a team that's seasoned in airway management, the procedure can be done locally. And whenever you can do this procedure close to home, it's always better and it's recommended. So that's the other takeaway lesson, that talk to us, communicate, call, and we will manage. We try to do a Zoom call with all parties involved in a place that you live. And if it's a challenge, then you have to come to Jefferson. Although I'm trying, as I mentioned, to have a place, or at least one per continent, such a center excellence of a center of care or a center of excellence to care for FOP patients. Example: there was a young individual, 16 years old, fractures the humerus, the leg, the major bone of the leg. So we assembled a young anesthesiologist. This was in South Africa, in the Red Cross Memorial Children's Hospital. We simulated the surgical procedure, had the families, the surgeons, anesthesia team assembled together. We answered the questions. When I visited a year later South Africa, I saw the child. He recovered. They forgot that he had a problem. Very nice follow-up. So it happens. So actually in South Africa, we have a center and an anesthesia team, and a whole team that they can provide and care for a continent of 1 billion people. We have the similar centers in Europe, in Israel, US, East Coast, West Coast, and beyond. If you have any other question, happy offline to connect, communicate, and answer questions.
That's great, thank you. The next question is about wisdom teeth. And should wisdom teeth be removed in patients with FOP to avoid, the specific question was to avoid cavities. So I don't know if Clive or Corey, if one of you wants to respond to that, please.
Corey?
Sure. So with the wisdom teeth, what occurs is you always want to try to keep brushing, like what Clive was saying, brush the outer surfaces of the teeth. And oftentimes, if you can spit, go ahead and do it with a fluoridated toothpaste. And that will usually help. But if I wouldn't take them out just to prevent cavities. I would look at it more as if you developed cavities. If you developed cavities, then we would look into it, because you always want to understand that there's a risk of the jaw fusing shut, and that can be a complication of wisdom teeth removal just for the sake of taking them out. I would not do it as an elective procedure. I would do the oral hygiene, everything Dr. Clive was talking about with the biofilm and making sure that you're in there brushing. If you have limited mobility, looking into some of those other toothbrushes that he showed to help with the brushing, or have someone assist with the brushing if the hands and the arms are limited. But I would not do elective surgery for wisdom teeth removal.
Okay, that's great to hear. There's a question about if any of the I say drugs that are given in FOP, we know that there's not an approved treatment for FOP yet, but there are drugs that are given to manage the symptoms, prednisone and other drugs like that. Do any of those drugs have a negative effect? Are they bad for teeth? Is a question asked by one of the moms.
I could probably answer that. The side effects of some of the drugs can impact teeth. So the side effects of dry mouth, for example, is quite common. And a dry mouth can be a huge risk factor in developing cavities. So drugs can definitely have an impact in terms of ongoing care. So please be sure that you are aware of that. If you have any of those side effects, be sure that you are minimizing them by doing the appropriate interventions to take care of those side effects. Don't ignore them. At the same time, though, what's really quite interesting is that I've had a number of patients who are on drug trials where they have had some closing of their mouth, and there has been some reopening of the fixation of the jaw because they've been on the particular drug trial, which has been really interesting. Whether this in fact goes across the board, I don't know. A question has also arisen with respect to some of the drug trials in terms of, if I've got a complete jaw closure and I'm on the drug trial, can I get the heterotopic bone removed to allow me to have some opening? And at this point in time, as far as I'm aware, there is still completely insufficient evidence to allow for that to happen. And I would repeat, I would not recommend getting heterotopic bone formation removed if you're on a drug to hope that you can have a jaw opening. Hopefully that will come. As I understand it, this is not there yet.
Yes. Sure.
I just wanted to answer about the steroid. So Corey Crowe, I'll answer. Go ahead. I'll answer later.
Well, I just wanted to second with what Clive said. I have also interestingly seen with the drug studies, 2 families where there has been almost complete closure, and I've seen a reopening, which is exciting. But it's been slim on the cases I've seen it. However, I'm hoping to see more.
Answering the question about steroids.
Go ahead, Zv. Mm-hmm.
So just answer a question and then pose a question to Clive. We administer steroids during the surgical procedure, and we maintain steroid treatment for 3 days after surgery, and then you stop. So although we add steroids that patient may have not been using perioperatively, I don't think that it may add a challenge on the oral hygiene because the patient used it for 3 or 4 days, and Clive can add his opinion because the perioperative steroids are only short for the day of surgery and 3 days after.
Steroids itself, I don't believe is going to have an impact on the oral health, especially when given over 3 days. Long-term steroids might be a different story, but short-term steroids like that. I would add that you do not always need the preoperative steroids for dental care. So you can do like cleanings and you can do even fillings without the steroid. But again, it depends on the complexity of what's needing to be done. There was a question that I saw about the baseline. Should it be done? My recommendation is that baseline should be done at every single session that you attend with your child or as an individual, because it gives you a very good sense of your own complete health. There was also a question while I'm on here about the baby teeth had not been lost at up to age 7. Should the parent be worried about that? I think that there's a complete range of when teeth fall out, and it can be anything from the age of 5 right through to the age of 8. It would be a good idea to actually have a X-ray taken to determine what might be going on, because sometimes teeth that are not falling out can result in the eruption of the succedaneous permanent tooth in an incorrect fashion. So it is something that should be evaluated.
Okay. So while we're talking about losing baby teeth, I'll just do a plug also for the FOP Biobank. And through the Biobank, if you just go to ifopa.org/biobank, there is an opportunity. If you are living in the United States, we're only able to process in the United States right now for you to donate your children's baby teeth when they fall out. And the shed cells that are inside those baby teeth then are able to be used in research. So make sure that you check that out. The last question we're just going to ask really quickly, we just have a minute left, is someone asked a question about the sonic toothbrushes. So the electric toothbrushes, are those safe for people with FOP to use? What do you recommend, Corey, with those?
Yes, they're safe. They're very safe, actually, and it's a good idea. A lot of people don't use them correctly, and that they try to use a electric toothbrush as if it's a manual. What you want to do is you want to put it on a tooth and then have it do the work for you and move tooth to tooth to tooth to tooth and use it in that fashion. And that is a really good way of maintaining your oral hygiene and oral health.
Okay, even I was using that my electric toothbrush correctly then. So thanks for the tip, Corey. I appreciate it. Mm-hmm. So thank you so much to our panel today. I think we've all learned a lot about the importance of anesthesia, whether it's for a general surgery or in an emergency situation, and then also what we can be doing in oral care. And we're just grateful to this very dedicated team for spending time with us today. You will find their contact information on the website if you go to ifopa.org emergency. You will find the contact information for these dental and anesthesia experts on our website. Again, thank you for your time today. And I know you have a session coming up right now, so you'll want to log out of this session, and then you'll choose whether you're going to the Ability Toolbox program, complementary therapies, or to the grief and loss session. So thank you so much for your time, everyone. Enjoy your next session.
Thank you.
Thank you.
Thank you.
Okay, and I've got to jump to the next session.